And now for the clinical approach for the patient who swallowed a foreign body. Foreign body ingestion is a relatively common presentation in the emergency department. Although children account for nearly 80% of cases, edentulous adults, psychiatric patients, and prisoners also commonly swallow foreign objects. Children most commonly ingest things they can pick up and place in their mouths, such as a coin, buttons, toys, and crayons. Adults are more likely to have trouble swallowing meat and bones. Although objects can be located anywhere throughout the alimentary tract, there are several areas where they lodge more frequently. In the pediatric patient, most obstructions occur in the proximal esophagus at one of 5 places: the cricopharyngeal narrowing, which is the most common, thoracic inlet, aortic arch, tracheal bifurcation, and hiatal narrowing. In contrast, most adult patients have distal esophageal obstructions caused by a structural or motor abnormality, such as a stricture, malignancy, scleroderma, or achalasia. Most adult patients will be able to relate to history of ingesting a foreign object or of feeling food becoming lodged. These are the adult patients. They may complain of anxiety, foreign body sensation, chest or epigastric pain. Also retching, vomiting, wheezing, or difficulty swallowing. In children, the history may be less clear. Parents may have seen the child with an object in his or her mouth and suspect ingestion. And children can present with vomiting, gagging, choking, refusal to eat, or neck or chest pain. Increased salivation, drooling, or an inability to swallow suggests a complete obstruction. Patients with airway foreign bodies tend to present with more respiratory symptoms. And we will speak about this in table 17.2 in another video, which will be a table about swallowed versus aspirated foreign bodies. The physical examination should focus on identifying patients with airway compromise, inability to tolerate fluids, or active bleeding. It should include a careful evaluation of the oropharynx, neck, chest, and abdomen. Findings such as fever, subcutaneous air, or peritoneal signs should suggest perforation. In patients with a suspected oropharyngeal foreign body, direct or indirect laryngoscopy can be useful. Plain X-rays may help locate radio-opaque foreign bodies throughout the gastrointestinal tract and be used to follow their progression. And that is if repeated every 2 to 4 hours to follow the progression. Many foreign bodies are not radio-opaque, including chicken and fish bones. If plain films do not reveal the object, an esophagogram, computed tomography, which CT, or endoscopy are other options. If perforation is suspected, the esophagogram should be performed with a water-soluble contrast agent. If aspiration is a concern, barium is preferred contrast agent. However, barium can obscure the visual field if endoscopy is subsequently performed. CT can be useful to identify the location and orientation of swallowed foreign bodies, as well as the presence of any complications such as perforations or fistulae. Endoscopy is usually the study of choice because the object may be removed once it is visualized. Some success have been reported using metal detectors to locate and follow metallic objects. weird. 80 to 90% of patients with normal gastrointestinal anatomy will pass swallowed foreign bodies without complications. Thus, most patients are treated expectantly at first. If symptomatic, in-hospital observation should be considered for serial examination. In general, once a foreign object passes the pylorus, it will continue through the GI tract without incident. However, if it cannot pass the esophagus or pylorus, it must be removed. Again, endoscopy is usually the method of choice. However, surgery may be necessary if there is evidence of obstruction or perforation, if the object is too big to pass safely, or if it contains toxins. There are several special considerations when dealing with certain types of swallowed foreign bodies, such as bottom batteries, which generally need to be removed because of their toxic effects on mucosa. This is all for now. Next will be I'll be reading, inshallah, the table about swallowed versus spirated foreign bodies. Very short video, very quick, and following, inshallah, will be comprehensive questions and clinical pearls. Thank you very much for watching, and take care of yourselves.